So here we have a 50-year-old male, history of diabetes that we encountered at our street medicine team out there in the field in Coachella Valley. And we immediately diagnosed this gentleman with this deep hand infection, potentially tensor flexosynovitis infection with our ultrasound machine. He had some risk factors, diabetes, behavioral health a little bit, and some addiction, medicine, substance use disorder. So, we were limited on what we can do. Obviously, that is an emergency, likely requires surgical intervention. And so we, called 911. This patient that was sent to the nearest emergency department. The next day, I figured everything was fine. He went to the emergency department, assumed he was probably going to get the appropriate care. The next day, I get a call from Peggy, one of our nurses and patient advocates that works with us in this community partnership out in the fields, and says, "Hey, Dr. Cisneros, I have Joe." We'll call him Joe. "He's in my apartment. I broke the rules. I took him home. He's febrile. They discharged him from the emergency department. Then we end up, he doesn't look good, and he seems like he's tachycardic. I want to bring him out to your emergency department." I couldn't believe it, and I was shocked. I'm Dr. Cisneros, and this is Critical Conversations.
Do you love medicine? Real medicine. Medicine unfiltered, unpredictable, and sometimes unfair. Well, this is the podcast for you. Because whether you're already in the chaos or training to join it, you'll hear the stories that don't quite make the textbooks. Because in the ER, there are no scripts, just real cases, real physicians, and real perspectives. This is Critical Conversations, medicine, policy, and the frontline experience.
I'm on a social media fast, so I'm not getting on social media for my nerves.
I normally only get on social media on the weekends. So I'm Friday, Saturday, Sunday. I'm off Monday through Thursday. It just helps me, like you said, stay focused and whatnot.
One of the interesting things I saw before I'd logged off is an article about a surprising statistic about how many medical students are living below the poverty line and are struggling with food insecurity.
Listen.
And because, you can't really have a full-time job when you're working in medical school, right? Because it's just so time intensive and laborious. And then, where are you getting this money from? Especially if you have a family that's depending on you, right? And sometimes it takes a little longer than expected. But surprisingly, people think the unhoused or people experiencing homelessness look a certain way, or they expect it to look a certain way. But there's so many people right now experiencing below the poverty line problems, like can't afford groceries. I tried to buy groceries the other day and it was $300. And I swear I only bought a stick of butter and a piece of bread. And I'm just like, what is that $300 for? Okay. I couldn't understand it. I just kept thinking about, imagine the people who don't have it. What are they doing? And they have a family to feed, but that includes medical students, which is wild to say. Very wild.
I saw this post where people were talking about how there's like a Family Dollar almost everywhere. You'd be like in some rural part, driving from one place to the next, and it's a Family Dollar. People are saying like, oh, why they have those everywhere? And I'm like, do people understand that sometimes the Family Dollar is the only source of groceries for like 20 miles for some areas? And this is a Family Dollar to you, but this is a grocery store to someone else.
Yeah.
I also think that people tend to view people as what they're studying. Just because I'm in medical school doesn't mean that I'm a medical doctor and I have like medical doctor money. I am still a student. Because you're in nursing school doesn't mean that you're already a nurse. Like law school is just a school. You still have steps to becoming a lawyer. So you can't think that I have the resources of what I'm studying. I'm studying to gain access to those resources. So it's definitely a very skewed view of people that are in school.
Listen, like we told Dr. Estes, we're doing a podcast, but we still eat ramen noodle.
Yeah, absolutely. Absolutely.
Yeah.
People call me asking to borrow money as if I'm
Like,
actually
Can I borrow
working.
something?
2 seconds from selling oranges on the street.
Wait, no, you are the one who has the job, not me. This is my job right now.
When
School.
people hear doctor, they just get like real antsy, like, oh man, that's a big deal. I'm like, brother,
Right.
sit on Christ. No, it is tough out here in these streets.
Even being a resident, you're still on a very limited income, especially if you're like on a visa. You can't moonlight if you're on a visa. So like this is your income. And then people who are able to moonlight, sometimes they have kids, they have like family stuff, they can't moonlight. So you're still on this limited income, and you have to like of course pay taxes, you have to pay for your living expenses and then loans. So it's like, what are you really taking home for yourself at the end of the day? Like I don't have money to loan if I'm paying loans myself. So there's definitely an issue with the view of like residents and medical students and any kind of student really. It's like, take the student whatever out. Like if you hear student doctor, take the doctor out and focus on the student. That's what I am.
It's like student doctor.
Yeah, exactly.
Too loud on the doctor. Bring that down a notch.
Yeah.
You definitely have to whisper it.
Well, Jasmine, something always interesting happens to you. We always laugh about something that's going on. So I know that there has to be something in the last 30 days that has occurred in Jasmine's life that will probably make Ty and I's face scrunch up. What is it?
Actually, I had a very serious situation. Ugh.
What happened?
I decided I want to be more organized. Let me put my shoes away. I'm putting my shoes away, minding my business. And I like swing up to stand up, and I hit my forehead right here on the edge of my dresser.
Oh my
Well,
God.
I don't mean to be dramatic, but I fell to my knees. I fell to my knees and I started crying. And I was like, oh my gosh, do I have a brain bleed? Did I crack my skull? Like, is it spreading to my eye? I felt like my vision was going blurry. My eye was swollen. I was feeling it in the back of my head. Like, I
Oh
can't.
my gosh.
Your life is flashing before your eyes.
I didn't know what to do. And I was like, am I about to go to the hospital to tell my colleagues that I just hit my head? I think not. So that kept me home. But I have a little bump. And I took some Tylenol.
Oh, you could low-key see it. You could see it.
I'm serious. Right
Turn to the
here.
side.
Like
What was
right,
that?
this like little bump right here.
Oh, yeah, you can see it a little bit.
It hurt. I wanted to take that dresser and squeeze it like this. But I knew it would beat me. That hurt really, 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 really badly. I don't think I have a brain bleed. My vision is back to normal. But honestly, having that moment of like hitting my head made me realize we are all potentially like a second away from a life-changing event.
That's true.
If that, like, it hit me right here, if it was down a little more, that would be my eye. And that's the corner. Like, that could have really been serious.
Yeah.
And I was just sitting down thinking, there are people who go to the grocery store and they fall down. There are people who have different little events that cause them to require emergency attention. It's like, do they have access to it? At least I have a hospital I can go to. Like, I have insurance that I can go and see someone. But there's some people who have like a life-altering moment that changes everything, and they have no access to healthcare. Or like they have access to it, but they have so many complex medical issues that come up that it's hard to keep up. It's hard to get transportation. It's hard to sit and have to wait for appointments every other day. It really kind of opened my eyes to some of the struggles that people encounter every day when it comes to accessing healthcare.
Yeah.
And we were just talking about not having, struggling with money and different things like that. But I'm connecting this to people who are unhoused, who, do not even have a place to lay their heads, But if something like this happened, what do they do, or what do they know to do? And I know ERs are able to see everyone, but from an educational perspective, do they know that this could be serious? Or you know how sometimes when you've lived a certain way for so long, and this has probably happened to us, where we know we were talking about earlier how kind of our parents' houses are like cluttered or whatever, and you've lived a certain way for so long that you don't know that it could possibly be better, or what you're in is as bad as it really could be. So I'm wondering, like, when people are in those types of situations, do they know that, listen, you need to get help for that? That's not something to just live with,
Yeah. Actually, I don't think they do. Like, for the most part, I think working in EMS, you get to experience a lot of different types of patients. And for a lot of them, the emergency room was like their first and sometimes only point of care or access to primary care, because they didn't have access to insurance. So they had to go someplace that would take them, right? And at that point, when they're coming to the emergency room, it's like you've taken a preventable illness or disease, and it's gotten to a point where now it's an emergency. Yeah. It's maybe even permanent, right? And so a lot of them don't know what they have access to, what resources they have. They don't have that health education. They don't know what programs are out there to help them. And they think that this is the way of life, and they're just trying to adapt, and they kind of just adapt to, the hand that they've been dealt. So yeah, they experience a lot of health disparities, health inequities because of that. So yeah, that's a big issue.
Luckily, we have a guest today who is going to help walk us through this, and we call it street medicine. Today, we have Dr. Victor Cisneros, who started his street medicine team at the facility that he works at now.
Yeah, and Dr. Cisneros is actually a leader in social emergency medicine and health equity at Eisenhower Health. So I believe that this mobile care unit was really important to him to create this community outreach program that kind of just brought medicine outside of the walls of the hospital.
I think this is a really great conversation, especially for people that are interested in emergency medicine, because it's one thing to go and do street medicine on the street, but you also have to remember that there's a lot of like street medicine that happens in the ER. People are, like we said, coming in and they've lived on the streets for like 30 years, and maybe they do still struggle with addiction, and maybe they don't get to eat every day. And there are even small things like hygiene that they don't get to attend to every day that we need to be mindful of. I am very passionate about patient care. I am the resident that's going to go and get someone water, a meal, a blanket, an extra blanket, a soda, whatever, because sometimes the care actually has a lot less to do with something clinical and a lot more to do with just caring for someone as a person, as someone that, like, the way you would want your family member to be cared for. Yeah. So I think it's really important to have the understanding that you don't need to be on the street to deal with cases that are very similar to what you would see on the street. You just would happen to have, of course, more resources in the hospital, but the scenarios are going to be very similar.
And what I love about this conversation with Dr. Cisneros is that I feel like he changed the conversation by changing our perspective or our idea of what an unhoused person experiencing homelessness looks like, right? So this is your grandmother who's living from paycheck to paycheck because she's on a sustained income every month. Mm-hmm. This is someone that comes from an underserved community who is working minimum wage and has 3 children and can't put food on the table. This is, like we said, a medical student who can't have a job, is struggling through school to make ends meet, and may be experiencing food insecurity. And just changing that perspective from the traditional living on the street, idea that we have of this marginalized community, it was really important and eye-opening for me. So I'm excited to have him and have this conversation.
Well, let's get into it. This is Critical Conversations. Let's do it.
Thank you, Joseph. Super happy to be here. Super excited to be part of this conversation. Super important.
We're just really excited about this topic and how it's going to unfold today. So just tell our audience right now who you are, what you do, and the work that you do in this space.
Absolutely. So, I'm a kid of an immigrant family, raised in Southern California. I'm an emergency physician by training, but I got to say I'm a public health practitioner. So that's kind of my passion and healthcare advocate. So my official title is I'm the director for community medicine and outreach at Eisenhower Health. I'm also the program director for a brand new fellowship in social emergency medicine and health equity. But so from that lens, that's kind of what I do. But my passion is public health advocacy and population health. Coming from a very humble background and underserved background, I'm a kid of an immigrant, knowing firsthand what it is to be food insecure, what it is to be potentially transiently unhoused. And so I think that's where that fire, and that little ignition was born. And I made myself a promise that if I had the ability to one of these days become a physician and a leader in the space, I would do everything in my power to, help those in need. And that's why I'm here. I'm driven by this passion. I'm driven by this fire. And there's a saying, if you do what you love, you never work a day of your life. And I keep that motto true.
As a public health student and prayerfully future emergency medicine physician, it's really great to hear about the work that you're doing. And it's also very encouraging to know that public health plays such an important role in the everyday life of an emergency medicine physician.
Absolutely. I think, so I got my MPH during medical school. I did a dual degree program, part of the Prime LC program, which stands Program in the Medical Education for the Latino Community. That's kind of my passion, being Latino myself and arguably large minority population in the United States of America. And so, public health gives you that extra tools that we don't get in medical school. Unfortunately, medical school is so compacted. We have 4 years to learn so much anatomy, physiology, pharmacology, that we really touch at a very small level, arguably probably just for what you need for your boards and your standardized tests. But, I think getting an MPH gives you some time, maybe an extra year or so, to really dive down into some of those real issues. And honestly, that's where I learned and I was exposed to the reality of how these social drivers really affect patient care. Having an MPH, and I truly believe, and I'm biased, obviously, that almost every physician, not just emergency physicians, need to have some public health background. And that even more prominent, in my humble opinion, in emergency medicine. As an emergency physician, you see everybody. You are arguably the closest thing of what represents your surrounding community. And we are the safety net. And so we are public health. Emergency medicine is public health.
So interesting you say that. I also have an MPH, and I always say, when I explain it to people, that they always ask, why emergency medicine? I say that emergency medicine is where medicine and public health meet. And I feel like that's what you just said. It's where the connection really happens.
Absolutely.
You mentioned something. So we recognize that medicine gives us textbooks. Hospital gives us protocols. But, backpack medicine is lessons that aren't really necessarily in our syllabus. What are some of those lessons that patients through street medicine have taught you that no classroom or residency could ever?
Yeah. No, I think the things you learn out there, you definitely cannot learn in a textbook. I say that patients on the street have shown me a resilience, resourcefulness that no textbook can capture. You learn how patients prioritize survival, choosing between food, medications, or shelter. How they reshaped how they think about care in the hospital is super important. And you start thinking about the things that really matter to patients. Many times a patient comes in and let's say they have a simple skin infection, right? Cellulitis. From an emergency standpoint, you prescribe an antibiotic, go home, follow up with your primary care doctor, and you assume that everything is great. A lot of assumptions are made there very easily. We all have done that probably at one point in our careers, maybe in our training. But we didn't really ask the questions. Does this patient have money to afford their medication? Does this patient have a transportation to go to a pharmacy? Does this patient have a home? Right? These are all things that will affect patient care, and so I think that it really highlights those things that sometimes we don't always put a lot of thought process and are not always taught in a traditional residency program or medical school education, right? So it's taught me to trust, and it's also taught me dignity, which are also very important for any clinical intervention.
I come from an EMS background, so I know how it is to kind of just be like a MacGyver in the field when it comes to dealing with treating patients outside of the hospital walls. For trainees stepping into street medicine for the first time, what do you wish someone had told you just about clinical care outside of the hospital walls?
Don't just focus only on the medicine.
Mm.
I think that's very important. Focus on being present, listening, and earning the trust of your patient. Many times these patients are very vulnerable. They come from a place where the system has failed them. The system has maybe anchored them or put them in a box that they might not necessarily see themselves in that box. I think it's important to gain trust and knowing that you're not always going to solve everything in one visit. And I always tell my residents, technology or your stethoscope or your ultrasound is only as powerful as the trust you have built with your patient.
It seems sometimes that in work, especially public health related work, where you don't necessarily have a formula for what you'll be presented with or a formula for how you'll be able to address an issue, it can seem like you just are putting a drop in a bucket. And it can be very overwhelming at times to know that there are going to be situations where you're very limited in what you can do and how you can help. So, how would you define a win when you know that you may never see a patient again, or when you know that something that you've done may just be a small step and the patient may not return for the rest of the treatment? How do you define a win, and how do you handle those situations where you may feel like there was no win?
A win could be not seeing the patient, right? Because that means that the patient now has a home. Maybe now it has a primary care doctor, and we've broken down some of those barriers. And so a win is always about a cure. I think it's about connecting the patient to care. For example, getting them ID cards, getting them dignity in that moment, right? Helping them with some of those social determinants of health that might not necessarily seem like a win to most people, but for that person, it's the world, even just a sandwich or maybe a pair of socks. And so it's those little small wins that I call that add up. And so I think helping them connect with those resources is a win in itself. And so you have little wins, I say, and then big wins. But all wins are important. And sometimes a win is as simply knowing that they're going to come back and see you next week. I think that's a win sometimes in itself because you know that at least someone's keeping an eye on them.
It feels like just so far in this conversation, and this is what I really enjoy about public health, it feels like a big hug. It's just like, oh, right. And because of that, what do you think some of the biggest myths about street medicine are, even maybe among fellow clinicians or as you teach residents? Like, what are some of the biggest myths they may walk into, but after going out and doing the work, they believe, oh, I thought that it was this, but it's not that at all.
One of the biggest myths in street medicine is that sometimes it's considered the quote unquote less than or not quote unquote real medicine. But in reality, it requires, in my opinion, the most innovative, patient centered, evidence based care. Why? Because innovation, you have to think outside the box. Many times you don't have all the tools. And I think this is where the emergency medicine training comes in handy because we do that in our training every day. Someone comes in, you might not know what walks into those doors. You might not have all the resources, and you might have to, what we call MacGyver, some of these tools out there to, do a life-saving procedure. And so that builds these critical skills that many times we can adapt out in the streets. I think that's one myth, that it's like you said, it might be all hugs, but it's not. It is important. And even those hugs, like socks and food, are as equally important and sometimes even more important, right? And you're doing this preventative, or what I call harm reduction, which is not always in the context of like addiction medicine, but harm reduction could be in terms of just skincare. Out in the desert out here, we give sunscreen, we give hats. These important things is medicine, right? Feeding someone is medicine. I think these are the important things that I think the House of Medicine are starting to realize that if we don't address, we're not going to make a difference. And this is why public health or research is important. This is why training the next generation of medical students and residents to think from this lens. And in my opinion, not just emergency medicine. And this is why I offer our rotation. We have a rotation every single resident at our institution, not just in emergency medicine, but family medicine and internal medicine rotates through our street medicine program. Because at the end of the day, you're a physician. Doesn't matter what specialty. When you graduate medical school, you're a doctor, most and foremost. And so I think, why not at least expose everybody in training from at least a little preview of this lens, right? Kind of like in medical school, we get exposed a little bit of everything. And so I think this is why this is so important. I think it's a growing field, and I'm super excited of what's to come as it continues to grow.
This is the first time I know that I've heard that there's an actual residency program that is really encouraging this type of work. In order for this work to continue, there has to be great funding, there has to be great interest around it, etc. Do you worry that this recognition is used as a way to avoid addressing the deeper structural issues that make this work necessary in the first place?
Yeah. And to go to that, I believe we are one of 2 or 3 in the nation programs that offer this as a curriculum. I think there's a couple other programs that might be as an elective. And so I think it's super important that no matter, and I always tell my residents, even if you want to work in, Beverly Hills, or you want to work somewhere where that is more affluent, you're still going to encounter this patient no matter what. People are going to come in depending on what specialty. And yes, sometimes, street medicine is often celebrated as this heroic kind of subspecialty that you're going in there and, doing these heroic moves. But in truth, in my opinion, it exists because our system has failed to provide equitable access. Like I say, this food banks exist because people are hungry. If people weren't suffering for food insecurity, food banks would not exist. I want to emphasize that we can't always let this work distract us from what's the root cause, which is these structural inequities that are existing. And so it's important. And I don't think there's an easy fix to it, but it's something that has been going on for years. I believe that street medicine has resulted from this need that we know that the traditional forms of medicine confined to hospitals and clinics are no longer working for multiple reasons. And so we have to think outside the box. We can't expect people to come to us. We have to go to them. Say you're a immigrant mother that is out here, single mom, 2 kids, making paycheck to paycheck. Let's say she can barely afford to pay her rent. She can barely afford to feed her kids. Do you think if I prescribe a medication that might cost her $20, $30 a month, which maybe for many of us might not be a lot of money, maybe some residents here might say, yes, a lot of money for me, but,
I met students.
and medical students, but for her, it could be the decision between feeding her kids and getting her medication. So any mother in her right mind will always choose her kids.
Mm-hmm.
Feed her kids, put a roof over her family. And so do you think when she comes back a month later in DKA or gets admitted for her sugars being out of control, she's probably not going to tell you this. We're just going to assume that she is non-compliant. Everything was against her to fail. And I think it's a big task, obviously, and it's something that sometimes seems overwhelming, but this is why these conversations are important in the emergency department. And I always try to train my residents and medical students, say, hey, when you're auscultating, pressing a belly, ask someone very simple questions. Do you have enough money for medications? Do you have enough money for food? And also it goes back to one of your first questions, that this field has taught me not to be biased in terms of us making assumptions that just because someone does not look unhoused, that is not suffering from homelessness or food insecurity. There's people that look like you and I that have no money for food or medications. And unless we ask these questions in a very trauma-informed care way, in a very non-threatening, comfortable way, we're not going to get the right answers. And what's going to happen, these patients are going to go out there on their own and the system's going to fail them and they're going to come back sicker. And if you want to look at it from a healthcare business model, it's going to cost the healthcare system a lot more money. But I think arguably more important, the patients are going to get worse. So we got to start thinking about the root cause.
I recently actually read this article that surprised me that was saying that a lot of medical students deal with food insecurity and are too ashamed to say it. And so I feel like it's good to bring awareness to that, because people feel like if you don't look down and out, you don't need the help. Some of the people who do need the help are so prideful that they're not going to tell you they need the help. So I feel like being a doctor is a part of just looking past just the illness that you have to diagnose, but actually seeing what are some of these social determinants that these patients are dealing with that might get in the way of quality care.
Absolutely. And you read my mind, because I was going to mention that article.
You saw that?
Yeah. And it's something that is not
Crazy.
new. I want to say, food insecurity is something that I've been working on since I was a public health student. And I guess it's one of my niches. In 2016 or 17, the University of California released a lot of data that show that their undergrad students, close to 50% at the University of California, which is a huge university system, were considered food insecure. Oh. And that it's from all ethnic, financial backgrounds, in terms of, didn't exclude parents that were potentially professionals, which was astonishing. And I think close to a quarter, maybe 24 to 25%, graduate students were food insecure. So when I read that recent article, it didn't shock me, but it did shock me that we haven't made much progress. What I think it's so more important to really highlight is the current decision right now that has been made by our administration to stop screening for food insecurity at the federal level. That, in my opinion, is going to be a huge public health crisis, and it's going to be detrimental, because in order to fix a problem, you have to understand a problem, and you can't understand it without data and facts, because that's where you're going to see, where am I making the greatest impact? Where can I move the needle forward? It's unfortunately what's currently happening, because it's going to affect public health in years to come. Going back to that point, many times we see people in the emergency department in your clinic that might not look unhoused, or might not look they're suffering from food insecurity, and you provide them with these screenings or these questions and you're shocked. And many times in the street medicine environment, you'd be shocked. Those patients are addicted to substances. But many times they're educated fellows that unfortunately had a bad personal situation, they lost their practice, and it spun out of control. Behavioral health sometimes is so tabooed and so undertreated and sometimes so marginalized for many reasons. Obviously, lack of psychiatrists. My goal is to incorporate behavioral health, have our psychiatry residents and potential attendings, either via telemedicine, potentially come and staff that and provide real life behavioral health where it's needed.
With the recent shifts in Medicaid funding and strained public health resources, how do we see the future of street medicine evolving?
Yeah, I think it's two things. I think if you look at it from a federal lens, there's going to be a lot more barriers given the current administration and current approach they're taking. I think it's making it a lot difficult. Luckily, I'm in the state of California, where I'm currently at, in some states that are more open and don't always agree at the federal level. There's still some hope. I gotta say, there's still some hope. And currently here in California, for example, it's a billable ICD-10 street medicine. Not that I care about billing, and we don't necessarily charge for our services, but I don't know if I'm sure you guys know, being in public health students, the ICD-10 was created for data. It was more for tracking and research, and I think that's more important. And also it gives it some weight, and it gives it some credibility that now this is a real issue. And in my humble opinion, this is a branch of medicine that is going to evolve, and we have to becoming experts and really extending our resources out of the traditional confinements of what we're used to in medicine, which is a hospital or a clinic. We either sit there on the sidelines and say we're just going to wait till they get sicker and they come into the emergency department. It might be too late, and we know how that ends. Or the second option is we got to start thinking outside the box and going to them, to the streets. If we choose, I think, the latter choice, we have an opportunity to make a difference, not just in the individual, but in the whole structure of medicine. Otherwise, I think it's going to be a disaster.
From policy shifts and patient care to medical breakthroughs and healthcare shakeups, emergency medicine never stands still. But we're taking a quick break from the conversation so that we can catch you up on what's trending across medicine and healthcare right now. Welcome to Critical Conversations Frontline Triage, our rapid assessment of the biggest stories shaping medicine, healthcare, and the frontline. We don't just cover the headlines, we triage them. Every story gets one designation. You have waiting room, fast track, straight to the back, or trauma bay. Let's get into today's headlines. So our first headline is, now this is popular. Now everybody's talking about this. And I know you guys, you'd have to be underneath a rock not to see this. GLP-1 drugs and how basically the Swiss Army knife of medicine. Like, it started off like with Ozempic and Wegovy being like for weight loss. But in the midst of all of that, they found out it's been treating everything else, from heart disease to kidney disease to sleep apnea to fatty liver disease. It even improves fertility, and people have basically reported not wanting to drink or smoke on it. And that's just to name a few. There's actually more scientific research that's coming out that's saying it's been helping other things. Could this drug become one of medicine's most versatile treatments? And where was it all this time? What do you guys think?
So for me, this is trauma bay all day. What's fascinating to me is that these medications, look, they started off as diabetes drugs,
right?
Then, obesity treatment, and now, like you said, we're seeing benefits in heart disease, and kidney disease, and sleep apnea, and liver disease, and that really just says we're looking at something much bigger than just weight loss. Yeah. But we're also starting to see healthcare policy catch up with the science, right? Medicare has begun kind of expanding access to GLP medications just July 1st. Yeah. So that's a new dimension of the program. And to me, that's a sign that these medications are becoming part of a much bigger healthcare conversation. So the healthcare administrator in me is immediately starting to think about cost and access because, these medications can be incredibly effective if, they're done right. Also, I don't think we should create a false choice between medication and lifestyle. Nutrition and exercise are still the foundation, right? Me trying to eat better and get my protein goals and all that, it's still a part of the conversation. So these medications are just another tool for the right patient they can be, life changing for that patient. So that's why, to me, this is trauma bay all day.
I think I have to agree. When I think about the benefits to people who have addictions to things other than food, that automatically sends it off the charts for me. A lot of people struggle with substances, and some of the times the substance is something as simple as vaping. A lot of people are vaping, and there's so many consequences to the things that we do in excess. And I think we're gonna create healthier futures for a lot more people, which would hopefully have a ripple effect. There are people that are healthier in general, and there's less overcrowding of the emergency department. There's more room for actual emergencies. People can take care of themselves for longer. I think a lot of healthcare strain just comes from a lack of adequate preventative care. And if this can help people, I don't see why not. Granted, we're going to have to see how all of these new indications for the medication kind of play out over time with regards to side effects and long-term effects. However, as long as it's being monitored by a healthcare provider, I think it's great. Trauma bay for me.
I mean, before we move on, this is trauma bay all day for me, because I feel like JD said, we need to look at making it affordable for people, right? So that they can actually get the help they need. Mm-hmm. But then also taking away the stigma of using something we have to start looking at weight loss or issues with weight as a chronic disease, just the same way we look at anything else, so that there's no stigma with using medications to help you get there. Taking away that stigma and really just focusing on that. So this is a trauma bay. Keep our eyes on this, because I think this is going to be very promising. All right. So, okay, guys, another great advancement, a cure for Down syndrome. Researchers at a university in Japan achieved a major scientific milestone recently by using CRISPR gene editing to remove the extra copy of chromosome 21 in lab-grown cells. The genetic change responsible for Down syndrome. This isn't a cure, and it's not ready for patients yet, but it shows scientists may one day be able to target the condition at its source. So, what do you guys think about this one?
Okay, so for me, this one's fast track, and here's why. Because scientifically, I think this is fascinating because it shows, really how quickly gene editing technology is advancing.
Yeah.
But I also think this is where medicine and ethics has to move together.
Okay.
Because right now, this changes what's possible in the laboratory. It doesn't change what I can offer a patient tomorrow. It's really exciting science, but I think it's still too early, and that's why I'm putting it in the fast track.
How about you, Jazz? Heavy sigh.
Love the advancement. I'm also very curious. The questions that I would have would be, at what point is this introduced? Is this something that's happening in utero? Is the, what? How do we know it's going to work? What are the possible negative side effects of? Is it how likely is it to have a mosaicism? I think it can get to that borderline of eugenics sort of quickly. Mm-hmm. That's where I'm I don't know. I would say I put this in the waiting room for now. We always want people to have options, safe healthcare options. Please don't get me wrong. However, I think I put it in the waiting room for now.
Yeah, Jazz, I'm going to agree with you, waiting room this, because like you guys said, I think it's never wrong. It's never bad when we find advancements in anything. And that's why we have experiments and why we have trials, because the process still has to happen. They haven't done the trials. They haven't done the human trials. So I'm pretty sure they're going to do all those things to make sure that they understand how it affects people. They're going to tell the public how it's going to, be used properly. But like you guys said, that eugenics thing, it's going to be expensive. It's only going to be available to a certain demographic. And it's not the demographic that usually gets left behind. I got to see some kind of health equity happening in the process in order to make it.
And also, those that are affected with Down syndrome, I know a few of them who have lived long, fulfilling lives.
Yeah.
So, I mean, it's just interesting to see that this is the thing that we are trying to, gene correct. I don't know. It's a strange one.
It's kind of like the deaf community. A lot of them get very offended when you suggest like that you should be fixing them.
Right. Exactly.
So that's another arm of it. Yeah.
There are so many people that thrive.
Yeah.
Yes.
And it's like you're correcting this out of a societal preference rather than a medical necessity. And that's where I'm like...
That's it, Jazz. That's it.
But is it not a medical necessity? Because we don't...
There are complications.
We don't know Down syndrome as a normal, like a normal pathology. It's something that's gone different in our system, right?
Definitely, but...
Well, where do we draw the line?
I guess we just have to see how it unfolds.
Yeah, I agree. Okay, guys, that's this week's Frontline Triage, the conversation shaping emergency medicine beyond the hospital walls. If you want to stay ahead of what's impacting EM's frontline in real time, follow us on @CriticalConvosEM on all social platforms, or find our link tree at Critical Conversations Podcast, where we keep tracking these developments between episodes and breaking down what they mean for emergency medicine. We're not just covering emergency medicine, we're shaping the conversations that move it forward. Now let's get back to the interview.
I love this. I love the part about the behavioral health that you brought up too, because I feel like that's a big aspect that's missing that doesn't really get addressed as much as like just treating like wounds and other more immediate acute issues.
Absolutely. I mean, we know that besides, obviously psychiatrists, in my opinion, emergency physicians see psychiatric care probably the second most common chief complaint. In many emergency departments, it's big, because patients come in and they don't have their medications. They can't see a psychiatrist. They're not managed appropriately, or they're suffering from substance use disorders. And I think, now there's some new medications that potentially have some really good hope with long injectables, where we could maybe use them in the field to prevent patients from going into acute psychosis.
Oh, wow.
And I think if we have this collaborative approach, especially in academic institutions where it's our responsibility to teach the next generation of physicians, and we have residents that are eager and medical students, and we start looking at maybe some of these quality assurance projects and looking at some of ways to improve this environment, there's a lot of potential where we can do a lot of good with minimal resources and prevent revisits to the emergency department, prevent length of stays. Currently, in many places, so even in our institution, the length of stay is almost double or 3 times for someone that is unhoused. That is just one social determinants of health. That's not even looking at all the other ones. But yeah, so behavioral health is a huge issue. And I think the other thing is working with our partners and really realizing what's out there in your community is very important. Knowing your limitations and knowing that you can't solve every issue, and realizing, okay, what are my strengths and what are my weaknesses? And recognizing some of those weaknesses and saying, what partners in my community, what champions are there, and start breaking some of these silos and connecting some of these bridges and saying, okay, well, you have these resources that I don't have. Let's work collaboratively. And that's what we've been doing at Eisenhower, where we've teamed up with the Wellness Equity Alliance Group, and they do a lot of harm reduction. They do a lot of great work in the streets, because ideally we can't see everybody. There's so much need out there. Well, let's find a way where we can develop a workflow, and we can say, hey, let's send them to our partner, Eisenhower Health, which we already developed a relationship because of the street medicine environment. What we've developed now is they call our social worker and they do a warm handoff and they provide transportation for this patient. But we've developed these workflows where now we can have this patient referred to us, we get them admitted, we know they're unhoused, and now we can safely discharge the patient with a community partner that is going to follow them up as their primary care doctor. And so we're developing this space where ideally unhoused patients will have primary care, follow-up, and continuity care in the street, right? And we're developing that bridge. But anyways, I can keep talking forever. I know that well, you guys probably
Oh,
have
I
more
love that
questions.
you say collaborating with the community partners that are already in place in the community organizations. I feel like that's key.
I'm interested in what type of technologies are available when you're out doing this work. I've heard you say Echo, I've heard you say mobile showers, I've heard you say, things that I think people may not really know it could be available to them when they do this type of work. What are some of the other things that may be surprising to people?
Absolutely. And I think from to that point, it's important to understand a little bit of the history of street medicine. Jim Withers, who's considered kind of the forefather of street medicine. Traditionally, street medicine is backpacks, stethoscope, whatever you can carry in your pockets in a
Mhm.
backpack, and you're going under that bridge, and you're really just kind of, literally providing care with whatever you can carry on your back. That has evolved, and full disclosure, not too many years ago, a mobile clinic would not be considered street medicine. That has changed. But if your institution and you have the funding to do that, why can't I bring a clinic where we provide humane care and a space where there's privacy and a bed? Many times before a mobile clinic, our mobile clinic is 2 years. This February is going to be 2 years, thanks to the Houston Family Foundation who funded us. At the end of the day, in my opinion, patients deserve the same humanity and the same decency of getting a nice bed, being to do a proper exam laying flat where it's AC, good lighting, and privacy more important, and right, and be able to discuss these issues. And so to go to your point, we have both. Our street medicine is composed of the traditional backpack, and also now we have our mobile clinic. And our mobile clinic, it has 2 exam rooms, and it pretty much has anything that you would find in any urgent care or primary care clinic. It has a bed, it has stirrups. We have, ultrasound. We have butterflies that we take and hooks up to our iPhones when we're not near the mobile. We're thinking of getting EKGs in the near future, but we do have an EMR. We haven't released it yet, but we built an Epic EMR system for our mobile clinic, and we're hoping to launch it in the next couple months because the idea is we want to know when we see a patient there in the streets and they, for whatever reason, end up in our emergency department or local emergency department. We want to track that. We want to know for continuity of care. At the same time, then if we see them in the streets, we can follow them up electronically, right? And no IV medications yet, but we're working on it. We're hoping to be able to perform some IV. We're working on our license. Once we get our license, we're going to go full on, probably do a little bit more robust care.
Wow, that's so cool. So take us back to this case, right? So you have this 50-year-old. Walk us through this again and tell us, what happened?
So yeah, so 50-year-old we saw in the streets had a swollen hand that looked like a deep hand infection. Called 911 because the patient was clinically septic. And they took him to the nearest emergency department at this area. The emergency department there tends to, for lack of better words, not treat with equitable care a lot of our unhoused patients. But unfortunately, that was the nearest emergency department. And so the patient ended up there. Me being an emergency physician, I figured this is a straight bread and butter deep hand infection, requires likely a hand surgeon consult, or at least an admission with IV antibiotics. And I assumed that the patient was going to get taken care of. The next morning, I'm actually working a shift in my emergency department at my hospital institution, and the nurse that I was with out there, who's also she's a community partner, runs her nonprofit, calls me and says, "Dr. Cisneros, I broke a rule." I mean, what do you mean broke? I took him home. They discharged him from the emergency department. I'm like, what do you mean they discharged him? I mean, he was like tachycardic, febrile, had a huge deep hand infection. He should at least got a, nope. They gave him a prescription for an antibiotic, which was like, I think Keflex, which is not even the appropriate antibiotic. They sent him home at 3 o'clock in the morning because, our street medicine nights are usually from 5 to 8 o'clock at night, usually because it's really hot. So we go out at night. That's when they come out. And so by that time, it was 3 o'clock in the morning. They sent him home. And I was like, I couldn't believe this. I was like, how do they send this home? And this patient She unfortunately took him home, which is a rule she never does. She took him home just because she felt he was unsafe. She drove him to our emergency department. I saw him there. I spoke to our hand surgeon. Luckily, he was doing okay, but he was doing worse. Now his heart rate is like in the 120s. His white count was out of control. His hand looked worse. He ended up going to the OR emergently and got his hand drained by our hand surgeon and got admitted. He's doing fine. He did great. And actually, it was a great opportunity for him to have a discussion about his behaviors, his addiction. And we got him teed up with our addiction medicine colleagues in behavioral health. And to this day, he's been sober for over a year, and he comes out every week and now really talks to our patients and is serving more as a health advocate and mentor. And he shares a story, and he shares how if it wasn't for our street medicine team, he would be dead. But I think what the most important part is that, again, if you think about it from a health equity lens and not understanding, this emergency physician, who I don't know it was, saw this patient with a hand infection. Let's say it's just a simple hand infection. You're discharging a patient that is unhoused with no access to a pharmacy without giving them IV antibiotic with a prescription that he cannot fill. He doesn't have no transportation at 3 o'clock in the morning. He has no place to live. And you're just saying, go follow up with your primary care doctor. But even if this was a simple skin infection, at least give them a round of IV antibiotics. Try to figure out, do you have a pharmacy? How are you going to get your medication? Maybe, and I always teach my residents, if we have a patient like this, keep him in our emergency department. If anything fails, just keep him there overnight to the morning. If you don't have a social worker at night or a case management, keep him to the morning. It's the safest thing. This patient was already set up from the get-go to fail if he would have gone home. And if it wasn't for our street medicine team and Peggy she was there, and she was even as a nurse advocating for them, but she was dismissed. So imagine this patient even showing up without Peggy, or she's a nurse advocating for him. I mean, he would have been dead. He would have been dead the next day. And so I see it as a teachable moment for our team and a learning experience. But I think that's the beautiful thing about this case. It was a difficult situation. I think it highlights a lot of the, vulnerabilities with these patients. And this is why you have to really teach our medical students and our residents to think about these things and not make these assumptions.
So if you had to determine what a soundtrack or a song that described the rhythm or a day in the life of what this work was, what would that soundtrack or song be?
Oh man, I think it would probably, I was putting some thoughts in. I think I would describe street medicine in particular as probably jazz, right? Unpredictable, improvisational, and deeply human.
Wow.
I think that.
Love that.
So now, this is the segment of our show called Pass the Mic. And how it works is we ask every guest that we have to leave a question for our next guest to answer. And we also have our current guests answer a question from the previous guest. Which one would you rather do first? Would you want to answer the question from our last guest, or would you want to tell us a question that you want to leave for our next guest?
I can answer the question.
Okay. The question is, in medicine, the choices aren't always clear-cut. You're often working in shades of gray, balancing what's possible with what's right. How do you find the way to thrive in that space?
I think, in my opinion, you have to thrive by leaning into your values, your equity and your compassion. I think that's the most important part, because medicine, no matter in what space, it's never black or white. It's a whole shade of gray, I always tell them. And it's about humanity is the gray zone. I think humanity is that gray zone that we exist. Many times our learners want to put things in little boxes. And obviously sometimes people do present that way, but very few times people present like a textbook. And I always tell people in medicine is a spectrum of gray. Very few times do we see the black or white aspect that we learn in medicine. And so I think we have to lean into that dignity, that equity, and that compassion to kind of be able to drive forward.
I love that. I love that. And what question would you like to leave for the next guest?
I think that's a very, let's see.
Love putting our guests on the spot.
Yeah. I think, this is all a street medicine, and this is all from this lens, right? From this health equity lens. So I want to say, in terms of public health and health equity, how do we see healthcare evolving in graduate medical education? I know, but I would love to see how the rest of the leaders think that we should be doing when it comes to educating the next generation of physicians and medical students with our current health policies and our current barriers. Is there any dramatic change that we should be doing in terms of the way that we're delivering our education? And what I mean is, should we be including public health given the current policies, the current lay of the land? And is there anything that we should be doing currently in our medical education to start looking at this foresight? I know that's a big question, but I would love to hear what other leaders
That's
out
a
there.
lot.
I know. I know.
No, that was a good one. We have another segment because we love to break up like the seriousness of the conversations that we have on this show. So our next segment is called Pulse Check. We'll give you a sentence and we'll have you finish it.
Okay.
If resources, funding, and staffing were no longer a barrier, my dream street medicine program would include.
Yeah. My dream street medicine program would include a fully integrated EMR that would access across systems, housing first partnerships, mobile diagnostics, and extensive residence/fellow training tracks to sustain the workforce.
Nice. Hopefully we see that in the upcoming years.
I hope so. Yeah, I think it's going to be much needed.
Yeah. It's needed now, actually.
Absolutely.
As we wrap up our conversation today, our final thoughts are, if street medicine truly succeeds, does it disappear or does it simply become medicine?
I think, yes, in an ideal world, yes, street medicine disappears when healthcare access is universal and equitable. But till then, it remains essential, in my opinion.
On your toughest days, what keeps you going? What keeps you coming back to do this work?
The patients. I think it's their resilience, their humor, the humanity that reminds me why I became a doctor in the first place. I was an engineer. I worked for a pharmaceutical company before medical school, and I wasn't happy. Started volunteering in the emergency department, and I realized, why am I happier when I'm cleaning gurneys and interpreting in the emergency department, and I'm not getting paid than if I'm going to my 40-hour job? And I loved it. I loved being in the emergency department. And I realized that, that's where my passion was. And even though I'm super busy, I'm not, don't get me wrong. My schedule is super busy, but I don't always see it as work. I love it. I enjoy it. And things like this was why I was super excited when you guys gave me this opportunity. I was like, oh my gosh, this is amazing to be able to sit here and chat with like-minded individuals and to be able to disseminate such of this important information and create a space where people learn about this arena of medicine that might not be as highlighted or as sexy, as other areas of medicine. So I was super excited. I'm like, absolutely yes. When you guys gave me this invitation, because I think it's super important. And obviously the title and everything that you guys have done here is phenomenal. The way you've structured everything. Yeah. So congrats.
Where can people find you, Dr. Cisneros, if they want to learn more about you or the work that you do?
Absolutely. Email me, V Cisneros 2 at eisenhowerhealth.org. And then, our website, Eisenhower Health, we do have a fellowship. So Eisenhower Health GME, and you can just Google the social EM fellowship, Eisenhower Health, and it'll come up. And they can, if they're interested in the fellowship or if they're interested in any rotation for, residency or even students that are out there, we welcome them. We do offer a scholarship for those that are interested. So don't let funding be an issue if you're interested in coming out.
For those of us that are interested in maybe even helping out or donating, we love to leave our audience with some real call to action items. So what do you believe the unhoused truly need when people are trying to donate?
Yeah, no, I think, every environment is probably a little bit different. Even though we're in the desert, we still provide blankets. I know it's not as cold as the East Coast. It doesn't get as cold, but we still provide, where that might be more of importance somewhere in the East Coast where it gets really cold. But I think socks, clothing is always important. I think working with your community partners is probably the best way, whatever local organizations that are doing, because they're more in tuned in the community. They can tell you exactly the need. I think the best avenue is connecting with your local institutions and your local community partners because they know those intricacies and whatever legalities or things that in every state and even every county might be a little bit different.
Perfect. Thank you.
Yeah.
I really appreciated this conversation. I feel like when I was doing public health, people, particularly outside of medicine, were like, why are you doing public health and you're already in medicine? You're wasting your time. And I just kept saying, if you don't understand the difference, I don't know how else to explain to you that they're not the same thing. They sound very similar, but they actually don't function the same way. A physician with no idea of public health is not going to treat you the same as a physician with an understanding of public health. It's really important to see people actually implement public health policies and actions and thought processes as we do with patients. And it's something that I feel like I don't see very often, but I'm happy to have had this conversation and be able to be a part of this discussion where we can see that, hey, it actually does matter, and we see people implementing it in their practices every day.
Absolutely. No, thank you for having me. No, this has been a pleasure.
Street medicine shows us that care doesn't begin with walls or technology. It begins with presence, compassion, and the courage to meet people where they are. Dr. Cisneros reminds us that medicine is at its best when we see the person before the patient and the humanity before the diagnosis. Now, if street medicine can thrive in some of the most unlikely places, then perhaps the rest of healthcare can learn from it too. The challenge and the opportunity is to carry the same spirit of dignity, connection, and compassion into every corner of our healthcare system. This has been Critical Conversations, Medicine Policy, and the Frontline Experience. The views and opinions expressed on Critical Conversations are those of the host and our guest, and do not necessarily reflect the views of our employers, educational institutions, affiliate organizations, sponsors, or advertisers. This podcast is intended for educational and informational purposes only, and is not a substitution for professional medical or legal advice.